I always start these presentations with a kind of disclaimer that I'm not a gender clinician. I'm a neuropsychologist and I work on a epilepsy surgery program. So kind of what am I doing here? One of the reasons that I'm here is because there are lots of overlaps between my specialty and what I see happening in gender medicine, in that I work on a program that really is it's elective surgery, and we do it on young people, and there are all sorts of issues about evidence base for what we do, and also informed consent. And also the history of my specialty is very dark. It comes from psychosurgery, so there's a lot that we can learn from medical history that I think is also relevant here. So I'm going to be talking about the CAS review, and really what I want to do is give primarily parents and young people a framework to understand some of the reactions and responses to the CAS review that they will be seeing in the press. So I'm not going to tell you what to think, but what I want you to leave with is really just a framework to understand how to navigate some of those responses that people have seen. Now, we've heard, and you will have heard, a lot about the conclusions of the CAS review, but what we don't see quite so much is what the structure of the CAS review looked like. So the structure of the CAS review is was composed of literature reviews. It had quantitative research in there as well. It had really what they wanted to do was look at pathways in and out of the service. Now, some of the CAS review, she wasn't able to do what she wanted. She wanted to be able to follow up what happened to the children that had been through the GID service. She wasn't able to do that because the adult services wouldn't give the data up. She also looked at the differences, and we've seen this graph over and over again, the differences of who's referred into the service, and that massive increase in young girls being referred into the service. She also did a qualitative research review, and she also did a survey of the gender clinic. So this was a really, really comprehensive piece of work that took 4 years. So when we think of evidence-based practice and a pyramid of the evidence that we have, we've got kind of clinical consensus at the bottom of that pyramid, and then as you move up, you can be more sure if you've got evidence from randomized controlled trials. Right at the top, we have meta-analysis, where you bring together all of that information. And kind of near the top, you would have what we have in the UK, the NICE guidelines, which looks at all of that evidence together and draws it together. The CAS review, in terms of evidence, sits right at the top of that pyramid. So it pulls together all of the information, and it really looks at what is the evidence for the treatment that we are giving to these people. It would be fantastic if all of our services, our medical services, could have something like a CAS review, because this really does tell you, what do we know? So what did she conclude? Well, these were her conclusions. I'm going to kind of sum it up. And this is a quote from the CAS review. While a considerable amount of research has been published in this field, systematic evidence reviews demonstrated the poor quality of the published studies, meaning there's not a reliable evidence base on which to make clinical decisions for children, for their families, and also for the clinicians as well. So we don't have enough evidence. That was her conclusion. And it was mentioned earlier on today. Normally, when a government review comes up with something like this and says there's a treatment out there that we don't have evidence for, there's a big hoo-ha and people start to really sort of rally against that treatment. What happened here was people started to rally against the message. They didn't like the message. But I've just put a quote down here. So it's Hilary just saying it's absolutely right that these young people should get the best evidence-based treatment. So there is no sense that these young people should be getting a second-class medical service. So I'm just going to talk through some of the critical responses that happened with the CAS review. I'm going to look at what happened on social media. I'm going to look at what happened with individual clinicians and how they responded to it. I'm going to look at medical associations and how they responded to it. And then I'm also going to look a little bit at some of the papers that have been published in peer medical reviews as well. And I'm going to finish off by just looking at why some of the responses have occurred, and just using some of the knowledge that we know from psychology in terms of cognitive bias and what happens. Okay, so if we think about what we saw on social media, or one of the classes of response was just absolutely immediate. I don't like those. I don't like it. I don't like the conclusions. Okay, so it's just I don't like it, and this is what we tended to see in on social media. So absolute minimal engagement with the review. This was in literally minutes of the review coming out. So nobody, it's 400 odd pages. Nobody had read it at that point, but immediately on social media, what would happen is there was this kind of playbook where you just made stuff up about the review that kind of fitted with your version of how you wanted things, or your group's version. And then you just repeat it back and you reflect it amongst your group until it becomes a well-established fact. So the well-established fact that very quickly got onto social media and that were repeated over and over again were things like Cass ignored all of the positive stuff. She just ignored those. Up to 90% of studies were excluded from her review. She didn't include trans people in the consultation. She's holding gender-affirming care to impossible research standards. It's different to other medical things. And she's insisting on a double-blind randomized control study. Now, none of those things are true at all, but that just became the narrative very, very quickly on social media. And the problem was that started to kind of leach into some of the mainstream reporting. So when even on television reports and also in some of the newspaper reports, you would get these labels attached to the Cass review. So they would say things like controversial or discredited or much criticised. So those things were starting to those labels were starting to attach themselves to the Cass review. And this brings me on to my kind of first cognitive bias that you may or may not be familiar with, which is the Gell-Mann amnesia effect. So this is the effect where if you read something in a newspaper article and it's about something that you know, so you know about this, and you read the newspaper article and you think, they've not got that quite right, that's not right at all. And sometimes they've completely got the wrong end of the stick. You read that and you think, that wasn't right. And then you turn over and you read something about something that you don't know at all. And you just take it as absolute read that is kind of how it is. And that's what happened with the Cass review. So if you know about the Cass review, when you're reading it, you think, well, that's not quite right. They've not quite got that right. And they may be saying sort of irrelevant things about it. But then we believe the next things. The problem is a lot of people don't know about the Cass review, so they're going to take in what they've read about it. So this is just an example. I'm not picking on the National Geographic, but this is just an example. So if historians are in the audience and they read how historians are documenting the lives of transgender people, they may have a lot to say about that. If we read the science version of it as well, the scientists may have a lot to say about it. But we'll turn the page and then we'll read that sea slugs chop their own heads off. And we'll be really excited about that. And that's the sort of thing that we would, talk about. Oh, did you know that? Because it's that amnesia effect. If we read something that we don't know something about, we take it as read. And we're very uncritical about that. Okay, so people who don't like the conclusions, that's their kind of level of disagreement. But then we've got the people who don't agree with the conclusions. And these are the arguments that we need to be thinking about. Okay, why aren't you agreeing with those conclusions? And normally they will say, because I've got evidence that doesn't concur with that, that's not consistent with that. So when we're looking at disagreement, there's a hierarchy of disagreement that we can use to really evaluate the arguments that we're putting against something. And right at the bottom is name calling. So, it might be, well, you're just saying that because you're a bigot. You're a bigot. Just calling somebody a name. So that's right at the very bottom. And there's a lot of that, even in some of the more kind of highbrow responses, is just name calling. So, you're transphobic, you're a bigot. And then there's the ad hominem attacks, which is, well, you're saying that because you're a bigot. You're saying that because you're transphobic. Or you're right-wing, or you're being, paid by right-wing people to say that. And then if you move up the pyramid a little bit better, responding to tone. So it's like, well, the language used in the Cass review implies a bias against transgender individuals. And that reinforces harmful narratives. So it's not really engaging with what the Cass review said. It's saying, I don't like the tone of it. And then this is where a lot of the kind of the negative responses, it's just flat contradiction. It's like, well, no, that's not true. That's not the case. So it may be that puberty blockers are safe and fully reversible. They would just state that as a contradiction. But again, without any evidence, that's not really a valid disagreement. This is where we start to get into things that we can really engage with. So if you're looking at counter-argument, is somebody presenting an argument, they're not directly addressing the main point, but they might just present a counter-argument. So an example might be, well, puberty blockers have been used for years in children with precocious puberty without any problems, so there's not a problem here. So it's not really the main thrust of the CAS review, because that's not what we're looking at. And then really refutation, that's what we want. That's what we want. It's kind of like, well, okay, this is wrong because. So what you would be looking for is this claim is based on outdated research and here's a better, more recent study. That's what we want. If somebody can come up, can look at the CAS review and say that, that's when we engage. So, okay, we've got something to kind of work with here. And then refuting the central point, that's what we really want. So not nitpicking little bits of the CAS review and saying, well, she got this wrong. She used the word exponential and it's not quite exponential. That may be true, but that's not the central point of the CAS review. The central point is that curve went up really, really quickly. So the central point is really that's what we're looking for. And what we would like is, here's the firm evidence base of high quality studies that we can base clinical decisions on. So really, if you're looking at a criticism of the CAS review, unless they're saying that, they're much further down that kind of disagreement pyramid. So let's have a look at what how some of the psychologists who work in gender clinics and who work in this field have said about it. Bad news for our trans youth this morning. This was the day that the CAS review was published. Bad news for our trans youth this morning, but let's be honest, we knew it was coming. I've reviewed the WPATH guidelines. The consequences of CAS are out of step with better quality, more comprehensive reviews, and out of step with approaches in other countries. So just like, well, this doesn't agree with the guidelines elsewhere. So over the coming days, I and many other clinicians will be having a look at the final CAS review in detail and trying to answer the question, why was CAS unable to find the research needed to provide trans youth with vital medical approaches that the other countries found? Well, there's a really, really clear answer to that, is because all of those other things are based on expert consensus. And what this person has done is put expert consensus, instead of being at the bottom of that evidence pyramid, put it right to the top. So really kind of prioritised expert consensus. And there is a reason we do not prioritise expert consensus. It's because it's frequently wrong. And there's lots of reasons why it's wrong, and I'll kind of finish my talk looking at that. So in the 1980s, anyone who had a stomach ulcer, it was due to stress and it was due to spicy food, and they were told to calm down and stop eating spicy food. And then we actually found out it was a bacteria. And this really revolutionised kind of gastroenterology and it really, really changed the way that they work when we understood this. More worryingly, a more sobering story was really putting babies on their fronts or backs to sleep. So there was evidence in 1970 that if you put your baby on its front to sleep, it was a risk factor for cot death. So we knew this in 1970. If somebody had done a systematic review at that point, then you would have recommended that you put your baby on its back to sleep to reduce cot death. So that evidence was available in 1970, but the expert consensus for another 20 years was put your baby on its front to sleep. And a group in Oxford have looked at this and said that probably 50,000 cot deaths could have been prevented had people gone with the evidence. It's not that we didn't have the evidence. We had the evidence, but the expert consensus was not in line with that. So experts are frequently wrong. There are examples in oncology, in cardiology, in neonatal care. Time and time again, we get it wrong. And that's why we have that evidence pyramid, because it can overcome all the biases that make expert consensus wrong. What's interesting is that many really face strong opposition when they try to overturn expert consensus. It's a really, really common thing that whoever sticks their hand up and says, I think that may not be wrong, the group will round on them. Okay, so more things from the psychologist here. The biased and flawed CAS review is not respectful of trans youth. Well, that's a kind of tone. Other countries have completed much more in-depth reviews and come to very different conclusions. Well, that's contradiction, that it's not true. Beware of transphobic gender-critical clinicians. That's just name-calling. So not particularly helpful. There are multiple critiques from within the trans community. So in these kind of criticisms, what you get is this idea that lived experience absolutely trumps everything else. And lived experience is really, really important. Okay, so for many, many years, doctors did not listen to their patients, and their patients suffered as a result of that. So lived experience is important. And they really provide a perspective that is not available to clinicians. So I'm not saying do not listen to your patients. Absolutely, we need to do. They are really good at telling us how something feels. They are not really good at telling us how it should be treated. Okay, so if I have a heart attack when I'm 40 as a woman, I can tell the cardiologist what that feels like for me as a woman, and that may be different from what they're used to dealing with because they normally see men in their 60s and 70s. That's useful. That's a useful perspective. I can't then say to them what I would really like is a trouser stent and a whatever they would do. Okay, so I can tell them what it feels like, what they need to be looking at. I cannot dictate the treatment. And one of the real difficulties for experts by experience is that they've got a very specific kind of experience. So they know what it feels like for them. They do not even know what it feels like for other people who've got the same thing. And we know from CAS that there are many pathways in and there are many pathways out when it comes to gender dysphoria. And the problem is, if you've got a certain experience, you think that's right for everybody else. The doctor doesn't, because they've seen a whole range of patients. So that's where the kind of the clinical expertise is valuable, and it needs to be used in conjunction with lived experience. The other thing about lived experience is that they will pretty much always prioritise a treatment that provides immediate relief. So morphine. That's why we don't give morphine out just to everybody, because it immediately provides some relief. But in the long term, it is not the thing to do. The same with some of the psychological things. So anxiety, the thing that really helps with anxiety is to avoid whatever's making you anxious. But in the long term, that is not a good solution. So actually what works with anxiety is that you need to kind of get used to it and kind of feel that anxiety and then kind of build up your resilience a bit. The same with fatigue. If you're feeling very, very tired and you get more and more and more tired, what you want to do is rest. But actually, if you just keep resting, it's going to make your fatigue worse and worse and worse. So this is why lived experience is important. And again, I'm going to stress, I'm not saying don't listen. What I'm saying is it's a certain perspective. It needs to be matched with a doctor's perspective as well. Okay, so some of the responses in the medical literature, there's too much to kind of go through here. I'm just going to highlight two. There's the integrity project response from Yale Law School. I don't think it's been published yet. I think it's still on the website. It's changed a few times on the website. And then there's New England Journal of Medicine, really, really prestigious medical journal that has also produced a critique. So you can have a look at those critiques there if you just scan the QR codes. And then there's been some critiques of the critiques. And these are really interesting. I'm just going to kind of summarise some of them, but they really do identify an extraordinary number of just factual errors in some of these things that have been published. I mean, just things that you could really easily fact check. They've just got things wrong. And I would say that the quality of the criticisms of CAS are pretty much on a par with the quality of the research that she was looking at, and maybe because some of the same authors are involved. So just a couple of the errors of facts that have been highlighted by the critiques of the critiques. The misrepresentation of the WPATH guidelines. The critics said that CAS ranked the WPATH guidelines highly. but she didn't. She's rated them poorly on rigour and editorial independence, and also misrepresentation of detransition rates as well. There's also a little bit of confusion about what the CASH review was, which is why I started with that picture of the structure of it. This was not a clinical guideline. She was not coming up with clinical guidelines. She was looking at the whole evidence thing. So a lot of the criticisms have said, well, this doesn't conform to this guideline or that guideline as how to produce guidelines, but actually that's not what she was doing. She was looking at an evidence base. Lots of personal attacks on Hilary Cass herself in that she wasn't an expert in this thing. Well, you don't appoint experts because they bring all of the biases and all of the kind of, you don't want that expert consensus. You want to know, actually, what does the evidence look like? So that was a strength of the review, not a weakness. And then this idea that there was this kind of alleged secrecy around who was contributing as well. They criticised some of the systematic reviews and how they were put together. They said they said there's an insufficient search strategy. Okay. And that she'd ignored key studies as well, which was not true. The studies were in there, but she just didn't rate them very highly. Okay, so just for the record, just a couple of things. The review holds gender medicine to a higher standard than other paediatric practices. This comes out time and time again. It's absolutely false. No, it's the very low quality of evidence in gender medicine. It doesn't stem from a lack of randomised controlled trials. There's lots of things in medicine that we don't use randomised controlled trials. Brain surgery, we don't use a randomised controlled trial for that, but we've got evidence for it because there's other ways of doing it. So you need high quality evidence. And the problem here is that they were poor study designs, they're inappropriate comparison groups, really high attrition rates, so they're not following up the patients as they should do, and really inadequate follow-ups. Or simply they just haven't looked. They just haven't looked for what they should be looking for. The other thing, the recommendations of the CASH review are transphobic and discriminatory because children with central precocious puberty are prescribed puberty blockers, and no one worries about that. Well, that's also false because puberty blockers are used to treat an abnormal physiological process in children with central precocious puberty. But they're used to prevent a normal developmental physiological process in children with gender dysphoria. So medical treatments are based on the condition that you have, not your identity. So that's just false. So really what we're looking for, what you should be looking for, what anyone who's interested in this field should be looking for if they are looking to see, well, is the CAS review debunked? Is it flawed? Is it biased? What you are looking for is somebody to say, here is the firm evidence base of high-quality studies that clinicians can use to make reasonable, reliable decisions. So if anyone has said that, then you can use that because that's refuting the central point. I have yet to see any criticisms that have provided that kind of disagreement. Okay, so I've got 3 minutes, 2 minutes, maybe. So why might clinicians persist with offering a treatment that does not help? Because we've really got to think about this. Why would people persist with this? And if you look at the history of medicine, this happens time and time again. So there was something called Greek white that was used for centuries. And it was used for all sorts of things. It's kind of a white powder with astringent properties. People used to use it for eye infections particularly. It was also used for diarrhea. You could gargle it, you could put it in liquid, you could gargle it for tonsillitis. You could use it for period pains and hemorrhoids. You can mix it with honey, all sorts of things. This was a magic solution. Anyone who knows the history of medicine will know that Greek white is powdered dog excrement. So these people were putting powdered dog excrement into their eyes to reduce infection, okay? And that went on for centuries. It's not the only thing. So doctors and patients will persist with harmful treatments despite obvious harm. So mercury is a poison and it will kill you. It, again, was used for centuries. The most recent case, and this is what it does, I mean, it kills you eventually, but before it kills you, it pretty much destroys almost all your organs. It's a horrible way to die. This is a case from 2022 of a woman who continued to take mercury for a skin condition. Her skin condition got worse and worse and worse. She continued to take it. Patients will continue to take things, and doctors will continue to give things that actually harm people. And that's because cognitive biases distort our perception, and they perpetuate harmful practices. And if you look at the history of medicine, treatments are abandoned, not when they're harming patients, but when something better comes along. So we stick with things even while they're harming people. It's only when something better comes along that we stop giving these harmful treatments. And the reason for that is the way that modern medical practice is organised. So we are specialists. And we all become specialists relatively, we do a kind of general training, but relatively quickly we become specialists. And as soon as we're specialists, we start to look at what we're specialists in. So whenever somebody comes to see us, that's what we start to look for. And that's anchoring. So we're looking for the first thing, when somebody walks through my clinic if I'm working in epilepsy, first thing I'm thinking is, have you got a seizure? What kind of seizure might it be? That's what I'm looking at. I'm not thinking, could this be cardiac? Or could this actually be psychogenic? Well, I am thinking that. But there's mainly whatever your specialty is, that's the lens in which you view the symptoms that come through the door. And then you're looking for anything that might confirm that. So you've got your confirmation bias, okay? And then you're thinking about the availability heuristics. So you're thinking about the patients you've seen recently, and they've probably had the same thing. So again, you're sort of like, oh, well, I've seen a patient just like this, and that kind of confirms you in your bias. You then become really overconfident because you've diagnosed 20 patients this week with that very same thing. So you become extremely overconfident. You get a sunk cost fallacy. So the more that you've put into it, the harder it is to pull out. And then you've got the group dynamics of everybody else is doing this. And that's what the head department does as well. So it kind of continues through that. If you see that something is going wrong and you want to raise the alarm, that's really, really hard in a medical profession because whistleblowers are often punished. So one study of whistleblowers found that about 90% lost their jobs or they were demoted after they blew the whistle. Nearly 1 in 3 are subject to lawsuits themselves. People lose their home. People actually take their own lives. It's a really stressful thing to be a whistleblower. And if you look at the pioneers in paradigm shifts in medicine, they have almost always been ridiculed at the beginning and ostracised from their peers. And if you need a case example of this, so the Australians among you may know the case of Harry Bailey. He was a psychiatrist who pioneered a therapy, lovely name, a bit like gender-affirming care. This one was deep sleep therapy. So it sounds very benign. He actually was putting patients into a sort of benzodiazepine coma for about 6 weeks. Unsurprisingly, and he did that for all sorts of things, anxiety, OCD, all sorts of things. 26 of his patients died. So he had dead bodies piling up in his clinic. He still, to the day that he died, maintained that this was a great therapy. He could not reverse that. And he actually committed suicide whilst he was being, it was a trial for medical malpractice for killing his patients. And in his suicide note, he said, "Let it be known that the forces of madness have won." So right to his dying day, he could not see, despite the fact that there were dead bodies. And we see this if we look at Dr. Olsen and the way that she has responded to the study that she designed. So she designed a study and then didn't really want to publish the results of it, and noticed that doctors' clinical experience was often undervalued in discussions of research. So she did a study, it didn't confirm her clinical consensus, and then she actually said, well, actually, my experience trumps my results, and didn't publish the results. So I'm going to kind of leave you with this, which is really for us, being wrong feels exactly like being right, okay? And you never know you're wrong at the time. The only time you know you're wrong is when you've changed your mind and you're right again. And this is like really important for us because I'm going to leave you with a kind of last pyramid to start thinking about, and this is your hierarchy of thinking styles, because we are also subject to all of these biases. So we need to be thinking about this as well. And we need to be kind of at the top here. We need to be a learner. We need to be, I might be wrong. And we need to be engaging with people who are challenging our thoughts and using those two other pyramids, using the evidence pyramid and also using the disagreement pyramid to make sure that we are staying on the right line.